Okay, my name is Gracie Champion, and I will be the facilitator for today's echo session. Please note that we will be filming today's echo session for educational purposes. Please be sure to mute your phones and your pagers to minimize any disruptions. CME and CEUs will be provided for this event. Please see your email for details. We're going to go ahead and get started with the didactic presentation. I would like to start by introducing Chris Piromali. He's our ANTHC Palliative Care physician and will be presenting palliative care, gastrointestinal symptoms, constipation, and diarrhea. If you have any questions about today's didactic, we will have an opportunity to ask them at the end of the didactic.
Thank you so much, Gracie. So good to be with everybody. I just want to first start off and say thank you to Rana Johnson. I used a number of her slides from Constipation. I'd also like to give a shout out to CAPC, the Centers to Advance Palliative Care, and integrated a lot of resources from that, as well as fast facts and some other references. So this is such an important topic and conversation that we're going to have today. So look forward to any comments or questions that you have at the very end. So we'll go to the next slide. And, so there's a few objectives. One is there's this concept of, a lot of people have heard of total pain, but total constipation and diarrhea, I just put it out there just to say that it's so important that we're looking at a whole person framework with any symptom, especially with constipation and diarrhea. And being able to identify and assess common causes of constipation, diarrhea, and then looking at all the different pharmacological agents that are out there to treat these symptoms, and then also being aware that there are some important non-pharmacologic approaches too that we should always consider even before thinking of medications. So Cicely Saunders, who's a pioneer for palliative care, one of her famous quotes is, "Nothing matters more than the bowels." And I would agree with her. And so we'll go to the next. We're first going to talk about constipation. It is one of the most common distressing symptoms that patients face with serious illness. And, what's incredible is just how often it's unrecognized and undertreated. And we included some of the statistics that are out there, but just think, 50 to 90% of advanced cancer patients deal with constipation. And then when you're looking at non-cancer patients, who use opioids, you're looking at like 40%. So a huge chunk of our patients. And then when you're looking at palliative care, thinking 70%, it's so important that we have this on our radar. So what's interesting is you'll look at different references, and it can be really confusing because some people might think that constipation is like not having a bowel movement for so many days. We often want to fit it in a box. And what I realized looking at different definitions and different sources, there's not a universally agreed upon definition for constipation. So it's not so black or white. And so, the lack of the precision of the definition is one of the reasons why it makes it so challenging to keep it on our radar and to have consistency across different disciplines. Constipation, it may be the consistency of the stool, that it's too hard or is small, hard-sized pellets. It could be that the defecation is difficult or too infrequent. Or it may be that there's just decreases in normal bowel movement patterns. So again, just know when you ask your patients what constipation is, it may be something different in their mind. So it's important to get a little context of what they mean by that and get some more information. Now, one of the things, and again, I got to thank Rana for the pictures. I was just like, I got to use these pictures. They're great. But one of the things that's important is, again, talking about this concept of a total symptom. So in this case, total constipation. We have to look at constipation in a whole person framework. And so there are social, psychological, and physical impacts of something as simple as a symptom as constipation. So just think about how, especially in our villages, someone may only have a honey pot. They may not have running water. It may be difficult. You may be living with lots of different people. Especially when we talk about diarrhea, the social implications of isolation, discomfort, it impacts the whole person in so many different ways. And then you'll see some of the physical issues that come up. A lot of people don't even realize, but when you get constipated, it can even cause delirium and mood alterations. And of course, there's the typical things of nausea, vomiting, bloating, and of course, pain. So there's important things to think about with promoting normal bowel function. So there's the fluid aspect. So just imagine with patients, especially at the end of life or who have serious illness, a lot of times fluid intake is decreased. The other thing too is people's diets change, and so fiber may be different. Something to think about too is think how many of our patients who are coming in from the villages here in Anchorage, their diet completely changes because they're not, in their communities eating traditional native foods. And so diet can play a big role, and it can change your bowel patterns. Physical activity is an important component. And so when we talk about non-pharmacological approaches, like just the mere activity of walking and getting up and moving can really stimulate the bowels and help you to have a normal bowel pattern. And then something as simple as privacy, like with children, we see this commonly, like they don't want to poop at school. And so they have this fear of pooping at school or using a public bathroom. And so things like that cause people to get constipated. And so that's why, like, even in adolescents or in children, we'll see, that mere fact of holding it in causes your colon to absorb more and more water so that you get constipated. Now, there are a lot of different risk factors for constipation, everything from age. We're going to talk about many of the different medications that can lead to constipation. Again, as people get fatigued when they have a serious illness, they're not moving around as much. We already talked about dietary changes and the fluid intake changes. And so, who does this sound like? And again, it's a lot of our patients that we're taking care of that, have a lot of these risk factors. So we got to be proactive. And it's important to keep these risk factors in mind so that we can be asking the questions about constipation. And then think of all the different types of disease states, even electrolyte abnormalities that are out there. And it's a litany of different things that can lead to constipation. So just wanted to list those there as well. So there's primary constipation and secondary constipation. So primary constipation, looking at food, fiber, activity, and again, the issues of privacy. And it's important to know where is the bathroom and what does the bathroom look like so that you can be considering these types of things. Next slide. And then, as I mentioned, there's secondary constipation. So a lot of people have their anatomy altered through surgical changes. There's irritable bowel syndrome, and with IBS, there's a constipation predominant IBS. Cancers can have masses that can actually press on certain parts of the bowel and lead to constipation. And then our patients receiving radiation can get fibrosis of their bowels. We mentioned electrolyte disturbances, and so having high levels of calcium or low levels of potassium, and even with our like dialysis patients or end-stage renal disease patients, uremia can lead to constipation. And then looking at the spinal cord, because the bowel is innervated by different nerves. And so it's so important that you're looking at whether if there's a cancer, could there actually be a cord compression that's developed from a metastatic lesion. So you got to keep that in mind. And then people who have traumatic brain injuries or strokes or other insults like CVAs from whether it's ischemic or not can have autonomic dysfunction. So people who have paraplegia, it's something really important to know that you have to be really aggressive about knowing how their bowel function's working, because it could be life-limiting if they don't have normal bowel movements. And then it was on the list before, but diabetes and hypothyroidism can also be another issue of secondary constipation. And again, it's just unbelievable, all the different types of medicines and categories. And so I'm looking at Anne-Marie, our pharmacist here, who it's just incredible. So just realize, keep these categories in your mind, because you know, so many of our patients are on these types of medications. And just think, so many of our patients are on multiple categories of these medications, so they compound themselves to really slow down the motility of the bowels and to work in different ways that lead to constipation. Next slide. So opioids, that is like our biggest soapbox. So you have to remember that if you're on an opioid, it's absolutely going to lead to constipation. And so we need to be proactive. So anyone who is getting an opioid must have a bowel regimen. You got to understand that opioids bind to the smooth muscle of the bowel, and it really impacts the contractility of the bowel. So it slows the passage of the stool, which is important because that means that the fluid that's in the stool actually gets absorbed. And so you're going to get harder, drier, less frequent stools. And then it slows down the peristalsis. And that's another critical element too, is you got to know that the peristalsis is one of the other things. So that stool is not moving freely through the bowel. And therefore, you need to be thinking mechanistically. A stimulant is so important to make sure that you're helping to improve the peristalsis. And so we'll talk a little bit more about that as we look at different medicines to help with constipation. And it's so important that if someone's on opioids, you're always asking whether that when was their last bowel movement and the consistency of that bowel movement. So one of our favorite Bristol stool charts. So if you are journalers out there, this might be a great thing. You can choose the type of bowel movement you had. And so this stool chart can be so helpful because it just allows you to understand on the spectrum of, how dry is the stool and the consistency of the stool. But part of the assessment is not only asking when did they last have their bowel movements, but, what are those patterns, the consistency, and that's where the Bristol stool chart can be helpful. Knowing all the other symptoms like bloating, pressure, pain, nausea. Have they been passing gas? Because even our cancer patients, it can be so easy for them to become partially obstructed or fully obstructed. What are the aggravating and alleviating factors? We talked about all the medicines that are there. And then also the physical exam assessment. So looking at abdominal tenderness, distension. You want to make sure, are there bowel sounds? And then a rectal exam can be so important with the issues of impaction. And so, so that's just something to keep in mind. So again, the assessment is you got to be pretty thorough to get a good understanding of what's happening. So I mentioned fecal impaction. So the Centers to Advance Palliative Care have a nice kind of stepwise approach. So the two things that you need to really think about, if someone's constipated, you want to make sure that they don't have a fecal impaction. You want to make sure that they don't have a bowel obstruction, either a small or large bowel obstruction. And the reason why is because many of these medications, if you're trying to induce them to have a bowel movement with these medications and they're impacted or they have an obstruction, you can actually cause harm. And it could even be deadly if someone perforates their bowel without keeping this in mind. So digital rectal exam can be so important. So if they do have a fecal impaction, there's some good steps. So number one, using a Dukolac suppository, and you can do 1 to 4 and wait 2 hours. So if nothing's occurred, then doing a warm water enema with mineral oil to soften the impaction, or you can even just do warm water as well, and that can sometimes help to stimulate the emptying of the stool from the rectal vault and the distal colon. And then those two things actually kind of soften up the stool, so that then attempting a manual disimpaction, this can be incredibly uncomfortable. So just thinking about pre-medicating someone with both pain medications or an anxiolytic can be really helpful. And once they're disimpacted, then you can start to think about partially emptying the bowel. Again, looking at enemas, polyethylene glycol is another thing, or stimulants. So again, you want to make sure that you're clearing out the impaction from below before you start to work from above to have things move through. So again, a bowel obstruction, whether it's partial or complete, absolutely has to be on your mind. So you can find that out either through history, your physical exam findings. Imaging can be also helpful. So, again, finding out if they're passing any gas and having flatus. A simple plain radiograph can help you to determine whether there's an obstruction, and then a CT of the abdomen. So even someone who's on comfort-focused care, again, knowing that there's an obstruction can really help someone get the best symptom control possible. And then this quote from the American Academy of Hospice Palliative Medicine is just a reminder that there's a lot of limited research that's out there and evidence, and so it really is an art of constipation management. So we're going to go through some of the main medication categories so that you know about them. So treatment goals, the big thing is having unforced bowel movements at least every other day. So there's bulk laxatives, so psyllium, bran. One of the things that's important to know about bulk laxatives, not the best thing usually, especially at the end of life, especially with someone who's not getting enough fluid intake. So you have to be really careful because it can cause a lot of gas, it can increase symptoms, and there's the increased risk for obstruction. Then you have your lubricants like mineral oil. And again, so it's good to know that these can be used for short-term use. And you just have to be careful with chronic overuse because it causes like the fat-soluble vitamin deficiencies that are there. You also have to be careful too with aspiration risk in the elderly and the frail. And it usually takes 1 to 3 days for those to kick in. So both bulk laxatives and lubricants are ones that aren't often that recommended, especially in a palliative care population. Surfactants and detergent laxatives. So, oh my goodness, almost every person I think of, their first go-to medicine is to give Docusate. And I just want you to know there's such little evidence to no evidence. This should never be used as a primary bowel regimen for someone on opioids. It's usually well tolerated and safe, but what's interesting is it's so important to use Docusate and these surfactants with a stimulant if you're going to use them at all, especially for opioids. And onset's usually 6 to 12 hours. Next slide. Stimulants. This is the woo. Palliative care loves our stimulants. So Senokot or sinusoids. And bisacodyl is the one that's on formulary at our institution. But again, especially with opioids, and that's probably our biggest reason why people are getting constipated, this helps to stimulate the bowels. So it's actually working on the mechanism. It's going again, correcting the mechanism that's causing constipation in the first place. And so, we listed some recommended doses. Know that it can take 6 to 12 hours. The great thing, especially with these medications, is you can titrate them up to effect. So definitely recommend using stimulant medications. Got to be careful, again, if they have an obstruction. You would never want to use a stimulant. It can cause worsening symptoms, and again, you don't want to cause perforation. So if there's a fecal impaction or an obstruction, you got to be careful with stimulants in those cases. Osmotic agents is our next group. So polyethylene glycol is, which is also known as Miralax, really wonderful. Milk of, that's probably one of our main go-to ones. That's the most gentle. There's lactulose and sorbitol. And the nice thing about lactulose is it doesn't take as much volume, whereas polyethylene glycol, you have to get 4 to 8 ounces in, and that can be really difficult for some patients. So even though it's gentle, sometimes the volumes are not appropriate for patients. Milk of magnesia, if they have renal issues or you're worried about renal impairment, you can get magnesium toxicity. So you got to be careful with milk of mag and mag citrates. So again, osmotic agents are bringing in fluid into the bowel to help kind of flush things out. That's the mechanism there. Enemas should never be a part of a routine bowel regimen. They're uncomfortable, and but one thing is, I want you to know the two that are most commonly recommended are warm tap water and mineral oil preparations. You just have to be careful with like saline and like Fleet's enemas, like sodium phosphate. They can cause a lot of bowel irritation, electrolyte abnormalities, and the same thing with a soap suds enema. It can cause a lot of irritation. And then just some other agents. Metoclopramide is a promotility agent. It can be helpful too, but again, not a good agent to use in a complete bowel obstruction. Again, this is lower on our list of medications to use. You also have to worry about things like extrapyramidal side effects like tardive dyskinesias. Other medications that are pretty expensive, or I should say very expensive, methylnaltrexone, and then the next slide has the similar agent, naloxegol. So these two are peripheral mu opioid receptor antagonists. So if you have someone who you've done everything trying to give them a bowel regimen, it's not working, these are your go-to medications, and their onset is pretty fast. So if you do have it on formulary, it is something to consider if all your other agents aren't working. And then lubiprostone is a chloride channel activator, and so it's another thing that's been FDA approved for constipation, and it works on the small intestine. So these are just your backup drugs to have in your pocket if everything else has failed. So next slide. We're going to jump into diarrhea. So just a high-level view of diarrhea. So again, diarrhea can be extremely distressing, and just know that again, a total picture of diarrhea, understanding that it leads to isolation. It can be very embarrassing. People often limit their fluid intake just because of the diarrhea because they're afraid of having it, and it can cause a lot of fatigue and electrolyte imbalances. So there's two main categories, secretory and osmotic. The reason why I just put these up there is just to say it's so important for us to start thinking, what is the etiology behind the diarrhea? You need to do that even with constipation too, because if you understand what's causing it, then you can figure out what is the best approach to correcting it. So secretory, like bacterial toxins and infections, can lead to this. Things like bile acids and laxatives also cause secretory diarrhea, so you need to make sure that there's not medications or inappropriate use of your laxatives that's causing it. And then also there can be dysregulated intestinal dysfunction that's there as well. And then osmotic, again, looking at different toxins or things that you're ingesting that are causing too much water to come into the lumen of the bowel. And there's also mechanical as well as disordered motility that you have to think about. So intestinal obstruction can actually lead to diarrhea because the liquid stool goes around the blockage. And then there's disordered motility, which is caused by rapid peristalsis action. And so irritable bowel syndrome is a perfect example of that. And then the evaluation. just again, reviewing diet. Are there foods that could be contributing to this? Are there medications? Is someone taking their laxatives? So, you know, they misread the two Senecots that they should be taking. They're taking 8, you know, or something like that. So just make sure you're reviewing medications and the way people are taking their medications. And then, again, the quantity and quality of the stools. When someone says they have diarrhea, what do they mean by that? And then developing our approach. Like I said, knowing the etiology allows you to match up what medications are best. So someone has pancreatic insufficiency. For example, pancreatic enzymes might be helpful. If there's an infectious diarrhea, there are times where antibiotics might be appropriate. If it's HIV, there are certain viral and bacterial things that you need to be aware of that could be leading to this. And again, severe constipation and fecal impaction can cause this overflow diarrhea. So you got to keep that in mind. Next slide. And then general approaches, making sure that you're keeping up with hydration and doing sips of clear liquids versus parenteral hydration for severe cases. Those are the 2 things to think about. So keeping up on their fluid intake. Simple stuff like toast or crackers can make a difference. So keeping with those simple carbohydrates and replacing electrolytes and glucose. So, you know, you don't have to get Gatorade or something like that, or Pedialyte. You can make your own concoctions at home, and there's simple recipes that I'm sure that I'm looking at Gracie that can give you that. It's not that costly to replace your electrolytes. And avoiding lactose-containing products such as milk. And just realize it takes the gut time to get those normal bacteria back to their normal state. So you want to lay off the milk if you've had diarrhea a lot. It may take a few days before someone can tolerate it. So don't go for that, me being Italian, fettuccine Alfredo right away. You might want to hold off. So just, there's a lot of different medications, but the big thing I would say as we look at these different medicines is matching up the etiology to the medication. So there's absorbent and bulk forming agents like kaolin, pectin. There's your psyllium, which is also bulk forming. Antibiotics and bismuth, if there's infectious diarrheas, can be helpful. Again, if it's an infectious, usually it'll resolve on its own. Loperamide is an opioid which reduces peristalsis in the gut, and that's one that we commonly use, especially with our chemotherapy induced diarrheas that are out there. So loperamide can be helpful. Aspirin and cholestyramine is often used for radiation-induced enteritis that causes diarrhea, so that's one to keep in the back of your mind. And then the next slide shares just a few other medications to keep in the back of your mind. So if they have inflammatory bowel disease, there's different anti-inflammatory medications, and mesalamine is one of those that are usually like the first-line medications to use. I mentioned pancreatic enzymes like pancreolipase for pancreatic insufficiency. And an expensive medicine, but one that can be really helpful, especially for people who have like high volume diarrhea, especially from HIV or from their stoma, is octreotide, and it can be really effective for profuse secretory diarrhea. So, big topic. So again, another slide from Rana. So in this case, you can poop. You know, you get to poop and you get to poop. Everyone gets to poop. Or if it's diarrhea, let's hope you don't poop. Let's hope you don't poop. So I'm going to open up to questions in the next 5 minutes. And two, if you have any comments, I would love to just, if anyone, like to hear from Gracie and Anne-Marie if they have any highlights of things from a pharmacy perspective or dietitian perspective too. So.
I think one thing I'll add when you're that Chris really made a good point of is when you're talking to your patients about their bowel habits, always starting by establishing what their normal bowel habits are. As a dietitian, love to talk about poop. Sometimes I feel like I put patients on the spot a little bit, so just kind of reassuring them that it's okay, that we can all laugh and smile about it. But asking them, you know, what's normal for you. For some people, they're having a soft bowel movement every 1 to 2 days. Some people, it's totally normal for their body to have a bowel movement twice a week. And so really trying to establish what their baseline is and then what the symptoms they are having now.
That's good. And from a pharmacy standpoint, always thinking mechanistically, what are the drugs and why do we think the constipation or diarrhea is causing, and then choosing medications based on how they're going to affect why we think the cause is occurring.
Any other questions or comments out there?
Great. Well, thank you so much, and feel free to let us know too. The slides are definitely shared. Just wanted to share some good resources that are out there. So at our institution, we use Centers to Advance Palliative Care. There's a really good module that's on constipation. There's something else called FastFacts, and they have really great articles that are evidence-based that are not only on just constipation in general, but especially like opioid-induced constipation. And then there's a whole article, so the diarrhea section, I got a lot of the information from our FastFacts article, so that's another just really great resource. And you could just type in FastFacts Palliative Care, and it's all free for you to access FastFacts as well. So, and then the last thing I would share is we like the Primer for Palliative Care, which is the American Academy of Hospice and Palliative Medicine, has this great handbook. And they have a really great chapter on constipation and other symptoms. So another really great resource too.
Well, thank you so much, Chris, for that really wonderful presentation. I'd like to turn it over to Anne Marie for introduction.